Hello friends, welcome back. Let's learn in part 3 the connective tissue tumors. Okay, so both benign and malignant connective tissue tumors. So listen carefully. Okay, so coming on to benign connective tissue tumors. So there are many benign connective tissue tumors. So in connective tissue, as you know, I told you in beginning itself what is an epithelium, what is a connective tissue. So when you look into connective tissue, there are blood vessels, there are muscle fibers, there are bones. So there are fibroblast cells. So based on these natural cells present in the connective tissue, from those cells, there are many benign and malignant connective tissue tumors. So fibroma, pyogenic granuloma, giant cell fibroma, peripheral ossifying fibroma, central ossifying fibroma, juvenile ossifying fibroma, peripheral giant cell granuloma, central giant cell granuloma. And when you come on to the bony part, aneurysmal bone cyst, lipoma. Okay, so lipoma, periciform xanthoma, hemangiomas and lymphangiomas. There are also lymph present in the connective tissue. So based upon that, lymphangioma, nasopharyngeal angiofibroma, myxomas. Okay, so when you deal with that muscles, myxoma is present. Chondroma, okay, chondroma, then also benign chondroblastoma, chondromyxoid fibroma, and related to bone you have osteoma, osteoid osteoma, benign osteoblastoma, torus palatinus and torus mandibularis. So these are the benign connective tissue tumors. So in this, few are important in MCQ viewpoint, so we will be giving only the important ones, so listen carefully. Coming on to fibroma. So fibroma is the most common neoplasm in the oral cavity. If you see, fibroma is among all the individuals, if you take, fibroma is the actually irritational fibroma or a focal fibrous hypoplasia. The cause might be a small irritation in that particular location. It is the most common neoplasm in the oral cavity. Okay, if you look into the oral cavity among the population, the most commonly found neoplasm, okay, most commonly found neoplasm, it's a benign neoplasm, okay, is fibroma. So that's an important question which is routinely asked. So how do you see clinically? Clinically it is seen as elevated and the color will be normal color, normal to that of the mucosa. So you see into the picture, the color of that fibroma is similar to the same as that of the other regions of the oral mucosa. Okay, and they mostly sessile and rarely they are pedunculated. Pedunculated means they will have a stalk. Okay, they will have a branch like stalk they'll have. Okay, but in case of fibroma, most of the times they are sessile without any stalk. Okay, and if it is irritated, if the fibroma, that particular lesion is irritated, it becomes inflamed and finally it develops into an ulcer. And most of the times the consistency will be firm and resilient. It will be very firm. If you touch it, it will be very firm in consistency. Okay, or sometimes it might be soft also if it is ulcerated and inflamed. Okay, so these are the important points. Main important MCQ is it's the most common neoplasm in the oral cavity. Okay. Now histologically, how does it look like? So just look into that picture. Fibroma, as I told you, there will be rapid proliferation of the fibroblast cells. So look into the epithelium is there is a atrophic epithelium, and connective tissue is the one which is very prominent here. There are large bundles of collagen fibers. Okay, compared to the normal epithelium and connective tissue, here you have large bundles of collagen fibers in the connective tissue, and fibroblast also. Fibroblasts are producing the collagen fibers. Okay, so what is the main differential diagnosis of this fibroma? It's fibrous hyperplasia. So what is the difference? Clinically, if you remove the irritation, there will be some irritation or there might be some causative factor for the development of fibroma. In case of fibrous hyperplasia, if you remove the irritation, it will regress. Okay, it will resolve. But in case of fibroma, it stays on. Okay, no such regression happens. That is why it is a benign neoplasm. Okay, neoplasm does not subside even if you remove the stimulus. Okay, so that's the main differential diagnosis. Fibrous hyperplasia also has the similar clinical appearance, but differential diagnosis is mainly based upon the stimulant. Okay, if you remove stimulant, fibrous hyperplasia regresses. Okay, or it will get resolved, but in case of fibroma, it stays on. Coming on to next one, peripheral ossifying fibroma. It's a reactive lesion of the gingiva. So it is seen mostly interdentally, okay, between the tooth, okay, interdental papilla. Mostly involving the gingiva. Interdental papilla is mostly affected in case of peripheral ossifying. The most common location is interdental papilla. Okay, a reactive lesion of gingiva is peripheral ossifying fibroma, the most common. So in case of peripheral ossifying fibroma, there will be ossifications. Okay, from the term itself, in case of simple fibroma, what was the histology? There only fiber bundles was there. Okay, only fibroblast and collagen fibers were present. But in case of peripheral ossifying fibroma, ossification, some little amount of bony formation is also seen in the connective tissue. Okay, that is a picture shown there, histology picture. So there are some ossifications. Okay, there are some osteoid bond formation in the connective tissue. Okay, rest remains the same compared to fibroma. So that is the main histology feature. Coming on to next important MCQ question, that is central ossifying fibroma. So central ossifying fibroma compared to peripheral ossifying fibroma, I just showed you the clinical picture. Peripheral ossifying fibroma is seen in the interdental papilla. Okay, you can see it clinically. But in case of central ossifying fibroma, it is intra-bony. You cannot see it outside. It is within the bone. Only radiographically you can see the lesion. It is intraosseous neoplasm. Okay, within the bone it is intraosseous neoplasm. So that is the main difference between peripheral ossifying fibroma and central ossifying fibroma. One is seen outside and one is not. Okay, so in case of central ossifying fibroma, the most commonly affected jaw is mandible. Mostly the lesion is mandible. So this can be a practically oriented question. Okay, they can ask you the most common intraosseous neoplasm. It's an intraosseous neoplasm seen mostly in the mandible, and mostly females are affected. It is present as asymptomatic swelling. So the patient will not be having any other symptoms. Okay, it will be a slowly growing lesion, and you can see displacement of the tooth along the margins of the lesion. Also cortical plates and overlying mucosa will be intact. Okay, so radiographically there are 3 stages for central ossifying fibroma. That is very important MCQ point of view. 3 stages are: early stage, in the beginning of the lesion, the radiograph if you take, it will be radiolucent area without any internal radio opacities. You cannot see any ossifications. You can, just like peripheral ossifying fibroma, in case of central ossifying fibroma also, once the lesion progresses, you can see within the connective tissue ossifications, bony formations you can see. I'll show you the histological picture in the next slide. Okay, so in the early stage you can see only radiolucency. But as the lesion progresses, you can see both mixture. Radiolucent area becomes flecked with opacities. Both the radiolucent and radio opacities you can see. And finally, in the matured stage, when the matured stage of the lesion, if you take a radiograph, it will be uniform radio opaque mass. So this is very important. Okay, the MCQ viewpoint, this is very important. Radiology of central ossifying fibroma, it is divided into 3 stages. Early stage, second stage you have both radiolucency and opacity, and last is the matured stage where you see only uniform radio opaque mass. And the pattern of growth is very important. I told you the lesion is growing slowly. Okay, so you have an early stage, you have in between stage, and you have a mature stage. So as the lesion grows, the growth pattern is important. The growth pattern is a centrifugal growth pattern. Towards outside it is growing. Okay, it is not centripetal, it is centrifugal. Outside outline of the inferior border of mandible is in continuity with the tumor mass. So you see in the radiograph, just see the radiograph very clearly. You have an inferior border of the mandible. So there is, along the border of the inferior border, the lesion is growing. Okay, so because of that, there is downward bowing of the inferior border of the mandible. The mandible is also moving. You will feel like mandible is also moving in the same shape as the lesion. Okay, so that is why it is called as centrifugal growth pattern. So centrifugal growth pattern you see in a radiograph in case of central ossifying fibroma. Very, very important MCQ. Okay, also you will see downward bowing of inferior border of mandible. It's very clear. Sometimes only the radiograph will be shown to you, and all these features will be given in the question part, and you'll be asked to identify the lesion. Okay, so which radiograph it belongs to. Okay, what is your provisional diagnosis or final diagnosis based upon the radiograph and the details given. So this was very, very important. Okay, clear? Now this is the histology picture, just like it will be similar to that of peripheral ossifying fibroma. Just from that of histology, you cannot make out whether it is peripheral or whether it is central ossifying fibroma. See, you have to take a radiograph also. So in case of a central ossifying fibroma, you have same histology picture. Okay, you see a mixture of bony trabeculae and symptom like spirules as well as fibroblast and collagen fibers. Coming on to peripheral giant cell granuloma. So peripheral giant cell granuloma, as you see, it's a giant cell epulis, okay, otherwise known as giant cell epulis. Earlier it was considered to be a true neoplasm, but now it is considered due to as a part of trauma, an unusual proliferative response of the tissue to injury. Okay, most of the times it is seen anterior to the molars, and this is the clinical picture. Just look into the picture, it is the clinical picture you usually see in case of peripheral giant cell granuloma. So MCQ viewpoint, histology part is important in case of peripheral giant cell granuloma. See the histology picture. In histology, what you can see, can you see multinucleated cells in the connective tissue? You can see an heteropic stratified squamous epithelium on the top, and down in yellow I have given label multinucleated giant cells. Okay, they are actually modified form of osteoclast. So what are these giant cells? Actually, they are actually a modified version of osteoclast. They are actually a modified version of osteoclast. So this is how it appears. Okay, within the connective tissue you can see giant cells in case of peripheral giant cell granuloma. Coming on to next one, lipoma. Lipoma is considered to be a universal tumor. It is considered to be a universal tumor. Lipoma is considered to be universal tumor just because in our body most of the region we have fat. Okay, so in case of lipoma, lipoma can appear in anywhere in the body where fat is present. Okay, that is why it is considered to be a universal tumor. Understood. But the most commonly found neoplasm of the oral cavity is actually fibroma. Okay, if you are being asked is like that, it is fibroma. The most commonly seen neoplasm of the oral cavity is fibroma, but the tumor which is considered to be a universal tumor is actually lipoma. It is because it is present in almost all parts of the body. It can appear. So in the oral cavity, in the floor of the mouth, this is how it appears. Lipoma, it is from that of fat tissue, fat cells. It's actually slow growing neoplasm which is composed of mainly fat cells. Okay, even if you do starvation, okay, we actually lose fat from the normal fat deposits in the body, but not from that of lipoma. So some people will be doing starvation, right? So even if we do starvation, even if you do some diet loss or diet plans, if you do, there will be fat loss from the other parts of the body, but since this is a neoplasm, there will not be any fat loss from the lipoma region. Okay, so clinically they can be of three different types. Superficially you can see them, superficial form. Secondly, they can be a deeper lesion which is considered to be a diffuse form, and lastly they can be encapsulated form also. So these are the three different types, and most common site is tongue and floor of the mouth are the most common sites of lipoma. So it's considered to be a universal tumor. Now important MCQ is being asked is multiple head and neck lipomas are seen in which all syndromes, which all lesions. Okay, it's a very important MCQ question. Multiple head and neck. So in many parts of the body lipoma will be seen in case of Gardner syndrome. Secondly, in case of encephalocraniocutaneous lipomatosis. Thirdly, multiple familial lipomatosis, and lastly Proteus syndrome. Okay, so histologically this is the appearance. Fat cells, as you know, they are clear cells. Okay, they are clear cells, and the nucleus will be seen towards the cell membrane, towards the very periphery it will be seen. Okay, so they are mature fat cells, and the nucleus will be flattened and will be seen against the cell wall. So that is in between you can see the strands of collagen also. So multiple head and neck lipomas are seen in which are lesions? In Gardner syndrome, it's very important. Encephalocraniocutaneous lipomatosis, multiple familial lipomatosis, and Proteus syndrome. Coming on to next important lesion, that is hibernoma. Okay, what is hibernoma? So we have a different type of fat. Okay, that is brown fat. So benign neoplasm of brown fat is actually hibernoma. Okay, hibernoma is actually benign neoplasm of the brown fat, and it is mostly seen in the oral and pharyngeal region, and the term hibernoma was coined by Gray. Okay, the scientist Gray coined the term hibernoma because of its resemblance to brown fat of hibernating animals. So as you know, some animals are hibernating kind. Okay, so when there is a resemblance of this fat to that of the fat of the hibernating animals, the scientist Gray coined them as hibernoma. Okay, so hibernoma is the benign neoplasm of brown fat. That is also important in MCQ. When you take a neoplasm of brown fat, it is called as hibernoma. Its most common site is oral and pharyngeal region. Coming on to next important lesion, that is chondroma. So what is chondroma? It's the most common benign tumor of bone. is osteochondroma. So what does it actually? See the histological picture. You can see a mass of hyaline cartilage over there, the bluish in color, okay, bluish purple in color, okay, and they exhibit some areas of calcifications, okay. So here and there you can see calcifications in that purple shade. So that is chondroma histology feature. So it's the most common benign tumor of bone is actually osteochondroma. So remember only this point in case of MCQ. Now coming on to the neoplasms of blood vessels. Okay, so benign neoplasm of blood vessel is actually hemangioma. This hemangioma, it is the origin is from that of blood vessels. Okay, so it's of two different types, congenital type and vascular malformation type. So congenital means what? Congenital hemangioma means by birth the individual will be having the neoplasm. Okay, by birth the patient will be having. So that's a developmental anomaly. Okay, so otherwise it is known as a hemarthoma. Now second type is a vascular malformation. It might be due to some amount of abnormal morphogenesis kind. Okay, so that happens after the birth of the individual. It is seen only after the birth of the individual, whereas congenital is seen at the time of birth itself. The strawberry type of nevus and the congenital hemangioma will be very clearly visible. Okay, so but both of them, okay, both congenital type as well as the vascular types are both locally invasive property, means only it will be localized to that particular area. It won't be spreading kind. Okay, it will be locally invasive property. Now let's learn few important points, differences between congenital hemangioma and vascular malformation. What is congenital hemangioma? I told you by birth itself the individual will be having this neoplasm. Okay, so it's a developmental anomaly. So there will be abnormality of the endothelial cell proliferation. So as you know, a blood vessel will be having a endothelial cell layer. So there is a abnormality in the proliferation of endothelial cells in case of congenital hemangioma. Whereas in case of vascular malformations, you can see vessel morphogenesis. There is some abnormality in the arrangement of or the development of this vessel. Okay, that is vascular malformation. Okay, and in case of congenital hemangioma, what you can see, there is increased number of capillaries. Okay, whereas in vascular malformation it is morphological abnormality. So there is dilation of the arteries, veins and capillary. There is no increase in number, but the size is increased in this particular case. So that is a difference between, basic difference between congenital and vascular malformation. Just remember these 2 points. Okay. Now coming on to classification. So classification in the sense based upon which vessel is involved, whether a capillary is involved or whether a vein is involved or whether it is a cavernous type of vein or a artery. So based upon that you can divide it into a capillary hemangioma, cavernous hemangioma, hypertrophic type of hemangioma, racemose type, diffuse systematic type metastasizing, nevus venous or Pottwine stain type, and last one hereditary hemorrhagic telangiectasia. Okay, so among these you have to just remember MCQ viewpoint. Capillary hemangioma is the one which shows pulsations or numbness as the symptom. Okay, so the pulsation or numbness is seen mainly in capillary hemangioma. Now just note down the basic histological feature between a cavernous and a capillary. As I told you, here you can see in case of cavernous it will be large dilated blood sinuses are seen. Okay, so whereas in case of capillary, small capillaries are involved. There is endothelial cell proliferation of small capillaries. Okay, so that is the basic difference. In case of cavernous, you can see large dilated blood sinuses itself filled with blood, whereas in case of a capillary hemangioma within the connective tissue, what you can see endothelial cell proliferation. Okay. Now next important one MCQ is what is Sturge-Weber syndrome, or what are the features of Sturge-Weber syndrome. Okay, it is connected with this benign neoplasm of blood vessel, that is hemangioma. So mainly Pottwine stain type of hemangioma is seen in Sturge-Weber syndrome. So that is a main important, and Pottwine stain is seen along the areas of trigeminal nerve. So there is a clinical picture of a patient with Sturge-Weber syndrome. You can see the Pottwine stain which is along the innervation, okay, of the trigeminal nerve. And along with that you can see angiomatosis of the face, that is clearly seen in that picture. Leptomeningeal angiomas can be seen, contralateral hemiplegia, massive gingival growth will be seen in the oral cavity, and asymmetric jaw growth. So these are the other features of Sturge-Weber syndrome. Very important. Otherwise, it is known as encephalotrigeminal angiomatosis because the port-wine stain is seen along the areas of trigeminal nerve. That is why it is called as encephalotrigeminal angiomatosis. Okay, so remember the points. Port-wine stain is seen along areas of trigeminal nerve in case of Sturge-Weber syndrome. Other features are angiomatosis of the face, leptomeningeal angiomas, contralateral hemiplegia, massive gingival growth, and asymmetric jaw growth. Coming on to next important MCQ is Osler-Weber-Rendu syndrome, or otherwise known as Osler's disease, okay, or otherwise known as hereditary hemorrhagic telangiectasia. So it's a autosomal dominant syndrome, okay, autosomal dominant, and the main genes affected are endoglin gene and ALK1 gene are mostly affected here. And what are the features of this particular disease, Osler disease or Osler-Weber-Rendu syndrome? It's very, very important. There are features like telangiectasia, okay, you can see the blood vessels elongation, okay, telangiectasia you can see. Secondly, you can see recurrent epistaxis. You can see what is epistaxis means. There is frequent bouts of epistaxis, okay. So, and lastly, you can see positive family history for this disorder, okay. It's autosomal dominant. So epistaxis means they will be bleeding from the nose, okay. So the triad of telangiectasia you can see, recurrent epistaxis, and lastly a positive family history. So I'll show the clinical picture in the next slide. So what is the main feature of this particular syndrome? In this particular syndrome, there is defect in small blood vessels of skin and mucosa. That is why you can see the bleeding from the nose as well as small telangiectasia, okay. Small blood vessels are dilated. So that is the main defect. So there is small defect in the small blood vessels of skin and mucosa, and the most common site will be lip. The most common site of this is lip, okay. So this is Osler-Weber syndrome, okay. Let's see the picture. Now closely see the picture. The first one is showing the telangiectasia, okay. So if you see the picture, you can easily recollect in the exam. That is why I'm just relate and study with the pictures, okay. So Osler's disease main features are given as picture. So first picture is telangiectasia. You can see dilated small blood vessels. You can see on the skin and the mucosa. Secondly, what you can see, it's a commonest site is lip, okay. The commonest site is lip. You can see the blood vessel elongation and small blood vessel elongated are seen on the lip region of the patient. And lastly, it is a autosomal dominant. That is why a male patient is shown there, okay. It's a autosomal dominant disorder. And lastly, recurrent epistaxis can be seen. Epistaxis means they will be bleeding from the nose. I told you just now. So see in that picture, the patient is having bleeding from the nose. So when you have all these features together, it is Osler disease or Osler-Rendu-Weber syndrome. Now, what are the neoplasms connected to that of lymphatic vessels? So first benign neoplasm is lymphangioma. So it's a developmental anomaly. Again, it is a developmental anomaly. Again, based upon which lymph vessel is involved. Based upon that, we can divide the lymphangioma into simple type, okay. That is capillary lymphangioma. Secondly, cavernous lymphangioma. Thirdly, cystic lymphangiomas or hygromas. They are bigger in size. And lastly, benign lymphangioendothelioma, okay. So the main site is mainly tongue. So lymphangiomas, the most common site is tongue. There is a very important MCQ. In lymphangiomas are mostly seen on the tongue region. Papillomavirus type is mostly seen. Okay, so it is most common site is tongue. Secondly, palate. Then thirdly, buccal mucosa, and you can see gingiva and lips. So coming on to that of lymphangioma, as I told you, tongue is the most common site for lymphangioma. So you see in the first picture you can see macroglossia, the tongue is enlarged, and onto the tip of the tongue, anterior dorsal part, you can see a whitish lesion. That is the lymphatic vessel being enlarged. That is the lymphangioma, okay. Now second picture shows a lesion which is very important MCQ viewpoint, that is cystic hygroma. So what is cystic hygroma is actually, it's a cavernous lymphangioma of the neck of the neonates. In case of newborn children, you can see lymphangioma which is connected to that of cavernous lymphatic vessels. So mainly it is present in the neck region of the neonates, and this is known as cystic hygroma, okay. So what is a classical clinical picture? In case of cystic hygroma, it's a cavernous lympangioma of the neck of neonates. There will be increase in the size when the child cubs or cries, okay. When the child cubs or cries, there will be increase in size of the lesion. And because the lesion is located in the neck region, the patient will be having main classical symptom, that is a respiratory distress. Okay, respiratory trouble he will be having. And the main treatment part is, as soon as it is detected, you have to go a excision of the lesion, because lymphatic vessel, the cavernous lymphatic vessel in that neck region is enlarged in this particular case, and you have to do excision at an early stage, because otherwise it will end up in death of the child. Okay, because of the respiratory trouble. So the main differential diagnosis of cystic hygroma is actually capillary hemangioma. Okay, capillary hemangioma. So the main classical differential diagnosis is capillary hemangioma in case of cystic hygroma. So remember these points, very very important. In case of a lymphangioma, basic site is tongue, and just remember the picture, first picture, mainly it is seen in the anterior dorsal part of the tongue as a whitish lesion. Second picture is showing cystic hygroma of a child. It is mostly seen in the neonates. It is the cavernous lymphangioma of the neonates. Main trouble it causes is the respiratory distress. Okay, because of that, the patient will be having difficulty in doing respiration. Okay, so there will be an increase in size of the lesion when the child coughs or cries. So what you have to do as a treatment part, you have to do excision is at the early stage of the lesion. As soon as it is detected, you have to go excision. Okay, and the differential diagnosis, capillary hemangioma. So remember these points are very very important. So this slide is showing you the lymphangioma. The lymphangioma, how does it appear histologically? So as I told you, it is the enlargement of the lymphatic vessels. So what you can see in the epithelium, you can see which is superficial atrophic epithelium, and down you can see very close to the epithelium enlarged lymphatic vessels. Okay, because of the presence of lymph within the lymphatic vessels which are enlarged, that is a whitish appearance for the lesion. Okay. Coming on to the lesions of bone. Okay, the first one we are learning osteoma. It's a benign neoplasm characterized by proliferation of either a compact or a cancellous bone in the endosteal or periosteal location. So the location can be endosteal region or a periosteal region. So here there is either it can be a compact bone or it can be a cancellous bone. So it is a benign proliferation of this particular bone in this region. It is osteoma. Okay. And most of the times, important MCQ being asked is, multiple osteomas of the jaws are seen in which lesion? It is seen in Gardner syndrome. So see the radiological picture adjacent to that. So radiological feature, you can see in multiple areas, you can see the bony formations. Okay, radio opacity you can see. So that, but it is present in multiple areas. So this is the classical picture of a Gardner syndrome. Multiple osteomas of the jaws are seen in Gardner syndrome. So remember that. Coming on to Tumours palatinus. This is very very important. Image based questions can be asked. Okay, so this picture can be given, or any other picture similar to this, okay, can be given, and you will be asked to identify. Okay, so this is Tumours, classical picture of a Tumours palatinus. So the location is palate. So it's actually a hereditary pattern is mostly seen in case of Tumours palatinus. It follows a Mendelian dominant pattern. Okay, Mendelian dominant pattern, and along the midline of the palate you can see the hard palate, you can see the lesion. Most of the times it will be sessile, nodular or lobulated mass of bone which is seen along the midline of the hard palate. Okay. And histologically, if you cut and see under the microscope, it will be a dense compact bone or a shell of compact bone with center of cancellous bone. Surrounding you have the compact bone, and in center you have the cancellous bone, if you see histologically. So this is the classical picture of Tumours palatinus seen along the midline of hard palate. Remember that point, very very important, and note the picture also. Similar way, if you have in mandible, okay, bony formations in the mandible, it is called as Tumours mandibularis. Okay, so just note down the picture. Image based question can be asked from the same. Okay, Tumours mandibularis, this picture can be given. So this is actually bone which is present as a response to some kind of torsional stress or some kind of heavy mastication. Okay, the patient might be having some kind of stress due to some kind of heavy mastication, and this bony growth might be a result of this torsional stress developed from that of a heavy mastication. So this outgrowth of bone on the lingual surface, mostly it is seen on the lingual surface of the mandible, okay, occurring above the mylohyoid line. So that is a very very important point. Okay, it is mostly seen above the mylohyoid line, usually opposite that of premolar teeth. So remember, relate and study with the picture. It is mostly seen along above that of mylohyoid line and next to that of the premolar teeth mostly, and mostly they are bilateral. So remember the picture, they are seen on both right side and left side. They are frequently bilateral. They are asymptomatic, no symptoms will be there. Okay, they will be slowly growth will be present, and they will be seen as either solitary nodules or multiple nodular masses. Okay, clear? So very important.